Thank you very much. It's great to see so much dialogue happening at the tables. That's one of the reasons we're at the circular tables, because I think that one of the purposes of coming together is for us to get to talk. Did you know that there's more than 50 different organizations represented here in this room? That's how fragmented a lot of us are all the time. So it's really such a privilege to be able to come together with people who are interested in this and really learn together. I wanted to introduce a panel which really highlights very rich collaboration, both between a community health center and a general hospital, and between psychiatry and oncology, between nurse practitioners and visiting nurses. I'm going to turn it over to our chair, Dr. Jerry Rosenbaum, who's just been such a wonderful advocate for the need for this type of collaboration. Jerry.
Thank you, Kelly. So this panel's title is Meeting Patients Where They Are, Hospital and Community Collaboration. And it's going to demonstrate an instance of really what we're talking about, highlighting an individual with severe schizoaffective disorder, active alcohol use, HIV, who has been cared for in our MGH Chelsea Health Center, a person who developed a curable anal cancer, and despite encountering multiple challenges and his severe psychiatric symptoms, was able to participate in a collaborative care trial, complete his treatment course, and receive recommended chemotherapy. So the idea is to present this case chronologically from the perspective of the caregivers. So to begin with, let me just introduce the panel at the beginning. So we have Diane Greer, who is a medical director of the Chelsea Health Center Mental Health Services Unit. Mary Lyons Hunter, who is the unit chief of that group. They'll be followed by Lorraine Drapek from radiation oncology at MGH, and Megan Gomes from the care dimensions. And each will give their experience in working with and encountering the patient and how things move forward. And in the end, we'll have a discussion from Dr. Inga Lennis, who is Senior Vice President for a variety of things, but including performance improvement and service excellence for the MGH Physicians Organization, also Medical Director of Ambulatory Services for the MGH Cancer Center, and Director of Clinical Quality for the Cancer Center, so she'll be the discussant. So we'll kick it off with Dr. Greer, followed by Dr. Mary Lyons Hunter.
Good morning. Okay. Thanks, Jerry. So Tom, as Jerry mentioned, is a 45-year-old man with schizoaffective disorder, alcohol use disorder, executive function deficit, whom I've been trying to treat off and on since 1991. If we're going to go chronologically, I was going to set the scene of his background. He's originally from Honduras. He was the youngest of 8 children. His mother abandoned the family to come to the U.S. shortly after he was born, leaving him with an abusive alcoholic father who turned him over in short order to an abusive aunt. He grew up sleeping on the floor, sexually abused, and from the age of 8 needed to work to support the family. In 1990, as a teenager, he fled to the U.S., trying to reconcile with his mother, but was summarily rejected in short order. He then came to our community, Chelsea, trying to meet up with his brother, one of his brothers, who also rejected him. And when I met him, he was living. He was one of, I think, 8 or 9 in a foster family. And shortly before I met him, he had, one thing I want to say is in Honduras, he had made 9 suicide attempts between the ages of 8 and 17, 3 by hanging, 3 ingesting gasoline, and 3 medication overdoses, none of which were treated. And shortly after he came, again, overdosing, tried to hang himself, and was hospitalized for 1 month and discharged, and very shortly thereafter killed the cat of the family and was then hospitalized for 4 months at McLean. And that was when I met him. So tried in the early 90s to engage him in care. He really did not want to think about or acknowledge or being mentally ill or needing medication or just really any of it. And that at that time, I was working in a clinic where the social worker who worked with him and myself, we did not have the same schedule, so he'd have to come in on different days, but he's very disorganized, so that did not work out so well. And then he left for about 8 years and returned in 2001 and engaged somewhat, but it was really a struggle. He would never accept a visiting nurse, for example, or a long-acting injectable antipsychotic, which he very much needs. His day-to-day presentation is that he drinks 2 to 3 cups of vodka a day, which is down from what he used to say were gallons. So that's an improvement. He's pretty much always hallucinating with either negative commentary or command hallucinations to kill himself or hurt others, hurt the dog. Olfactory hallucinations, paranoia, a lot of ideas of reference. Has gotten into a lot of trouble in the community. He's currently on probation for having slapped someone at local restaurant. He is often screaming in the street because he thinks people are looking at him. He's often trying to avoid the police because they've told him if they find him, they're picking him up. So he's darting in and out to avoid them as much as possible. I think that his treatment really took a turn for the better in terms of community psychiatry when Dr. Hunter joined into his treatment about 12 years ago. The clinic where we treat him is a place where previously, if he missed his appointment with me, I would not be there for another week, so that week would be lost. But now, if he misses a day, we're looking for him, and we can have him in the next day. And with his degree of disorganization, that has made a big difference. And also, Mary's been very proactive in engaging him and trying to help him overcome his barriers to care. Do you want to?
Sure. In terms of Tom, as Diane has elucidated, it's been like trying to hold mercury and trying to engage him in care. And my role has primarily been to collaborate with various agencies, various outside sources. He worked up until a few years ago, so working with his employer when there were issues with that, trying to get him on disability, other kinds of care management, advocating for him. But probably the biggest role, as Diane just mentioned, is sort of understanding and trying to reduce his barriers to care. And some of them are executive functioning, some of them are part of his psychosis. One of my most clear stories from Tom, one time he came in and he had stopped his medication, and I said, help me understand why you stopped the medication. And he said, well, the voices told me to. And I said, do you think they gave you bad advice? And he suggested that that's possible, but that he would need to have a meeting with the voices to discuss whether or not that he should resume treatment. So this is the kind of thing that we've done for many, many years in trying to engage him in compliance with his treatment and also just coming to the clinic. And when he was diagnosed with cancer, both Diane and I were really terrified. We thought, there is no way that he's going to be able to access treatment, get himself to treatment, stay with treatment, engage with other folks. We've known him, as we've pointed out, for a very, very long time, and at times he's afraid to come and see us. So we thought that there's just no way that there's going to be any effectiveness in terms of his treatment. So what are we going to need to do? He does live with a long-term partner who's really more of a very close friend, and are we going to have to engage his partner in terms of what this is going to look like? When do we, palliative care, as we talked about, and then this wonderful team of people arrived on the scene, and it was like an answer to a prayer, as you can imagine, because if we can't get him in to see us for his relatively benign visits, there was no way he was going to endure treatment. It just wasn't going to happen. I don't know if, Diane, you have any other comments to that?
It happened.
It happened, right.
I'm still marveling at that.
It happened.
So as a nurse practitioner from radiation oncology, I followed him, and I got a call from the oncologist that I work for saying, oh, I'm seeing this patient with anal cancer who is mentally ill, and can you take a look at the chart and see what you need to do? And what I read was what you just heard. So now anal cancer is a very curable cancer, but it's number one, an HPV cancer with a stigma. Number two, the pelvic area is treated. Sexuality can be very affected by this. Number three, it often requires not often, it does require intense treatment, chemoradiation, 30 treatments that cause pain as well. So we had this history with all the things that we were going to cause. I immediately called Kelly Irwin, brought her in on the scene. The positives in this, this was an overwhelming situation. The positives were I found out he had a team in the community, and he had a visiting nurse, so emphasizing the positives. We also emphasized with him in his lucid moments that he could be cured. He had a greater than 75% chance of being cured if he could go through the treatment. I promised him I would stick by him and help him get to the treatment, but he had to promise. He had to promise to come to the treatment. We arranged a lot of consistent systems for him. I had to meet his entire treatment team prior to having ever starting radiation. These people were involved. They were the same group that would, radiation therapists that would treat him every day. Their biggest concerns were fear of someone so mentally ill that they're not used to. More or less, is this a patient that could harm them? And I reassure them he wouldn't harm them any more than any other patient would. And also, sometimes mental illness is confused with learning disability, but he was not learning disabled. He fully knew, he could understand what the treatment involved and what he needed to do to take care of himself. Maybe not necessarily did, but what he needed to do. So we put these all in place in his lucid moments, and there were some times when he was not very lucid when I would see him weekly, but I would try to take advantage of the lucid moments and try to do some teaching, would correspond with his partner at home on things that he needed to take care of. We did have to really push and advocate for his first cycle of chemotherapy to be inpatient, because it involved a PICC line, it involved a pump, it involved a lot of overwhelming things. It was challenging. We got him through. He got his first week. But after that, he needed one more cycle, and he knew what was going on, and he wanted to accept the challenge of doing it at home, and we did do it. In his whole course of treatment, he missed 3, which was pretty good, and we did make up those 3 treatments. On the day he finished treatment, he was in a lot of pain, for sure. He was at the end of treatment, but he was so happy. He got his diploma, and we all circled around him so that he could ring that bell very loudly. And he did, and I told him, I am so happy that you were able to do this. And I said, it really makes me feel so much better that you were able to do this. And his response was, I promised, and I couldn't let you down. So Yeah, the system worked. It's great when it does. This has been an inspiration to have been able to take care of someone so ill. And, you know, his other problems take precedent. He is now, almost a couple of years later, likely cured of his cancer.
And I just might add, Dr. Greer and I saw him this week and told him, and actually asked if it was okay if we talked about his case, if it was, you know, obviously not using his name. And he was so happy that he could maybe help and teach other people about what it was like for him. And he was really delighted that we would be able to tell his story.
It's really, I think, a very strong testament to a lot of people working very hard, you know, outside the lines of their job description, to give somebody the type of individualized care that makes sense for the person. A lot of proactive work. I will add that in the midst of this, he consented to be part of a clinical trial. His caregiver consented to be part of a clinical trial. He completed all of the assessments. He provided interviews, and many times he expressed his gratitude for being included in a clinical trial. And so here's an example of someone who, by any standard, has significant psychiatric symptoms, addiction, and yet he also deserves life-saving treatment, which sometimes is a psychosocial intervention. When someone's biggest comorbidity is addiction and schizoaffective disorder, this is the chemo, this is the immunotherapy, this is the innovative work that they need. I'm actually here not to talk about that, though. I just couldn't help myself. Sorry. What I really wanted to just quickly say is that the other piece of his team was an incredible visiting nurse who I have in my phone as another patient's name, BNA, because I happened to work with her with 2 other patients in my other job as running a clozapine clinic 2 years ago. And she was the type of visiting nurse who, if you go to the door and the first time the person doesn't come, she goes back. And she goes back a second time. And she was so critical to this, to being able to give that second round of chemo and for us to feel at all safe about it. And so I just feel like, you know, I would really want just to say that that was the other piece of her care. And I think then I'll turn it over to Dr. Lennis.
It's a pleasure to be here today. I was not the treating oncologist for Tom, but I'm here today to talk from that perspective and to give you some thoughts, not only as an oncologist, but also in my administrative role. So I work for, as Jerry said, I work for the hospital and for the physicians organization. I'm one of the senior vice presidents over at MGH. And I have a few thoughts. I think as an oncologist, I'll say that when we encounter patients like Tom, the first thing that happens is our heart beats a little faster, and we look for our team. You know, that's, I think, the thing that sets apart a great practice that we have at MGH are the amazing team members that we have, because at the heart of what we do every day is the feeling that if there is a curable cancer there, if there's anything that gets in the way of being able to deliver a curative therapy, like Kelly was saying, the most pressing comorbidity for this patient may not have been his cancer. It was not. It was his illness, his mental illness, and the needs that he had around that. We want to move heaven and earth to be able to work with our team members to be able to deliver the care that we'd like to cure cancer. It's ingrained. It's almost like how we wake up in the morning. And I think that the perspective that I've seen really shift over the past 10 years is the understanding that it cannot be done in a vacuum. It just can't. And that when it comes together with the pieces that you heard about today, with not only our colleagues in the hospital, because we must work very closely with our radiation oncology colleagues, our nursing oncology colleagues, our pharmacy colleagues, our physical therapy colleagues, you name it, our inpatient colleagues. What I think this panel really highlights are our community colleagues, which I think is sort of, as we grow these concentric circles of family around patients, that is I think in the past 10 years, I've seen a shift from a smaller circle that was actually pretty close in in oncology. And sometimes that close-in circle didn't always even include, say, for example, pharmacists, which I think over the last 10 years, we've seen that shift. It's not even a question anymore if that inner circle involves pharmacists, nurse practitioners, many different members of the team. I think the next frontier is pushing that circle, understanding that those team boundaries are inclusive of our community friends and colleagues, the help that we have closer to the patient in their environment every day, our mental health colleagues, social workers. The team is larger, and that family and that tent needs to be that big to be able to deliver the kind of life-saving care that this team did for Tom. So my feeling as an oncologist is the feeling that you have when you see a situation that makes you nervous, a situation that you need to stand up and face, and that feeling that you have when you turn around and you see people behind you that have your back, that are there, that will be there with you, and that you have theirs as well, especially during the more difficult times. And I have to say that as an oncologist, it makes this work even more rewarding than it can be. So that's sort of me personally, and I have my personal stories of great collaborations with Kelly and community colleagues and the rest of the team here. I think I want to pause for a moment and wear a different hat. So in the role that I have at MGH, when I heard Dr. Rosenbaum and the rest of the panel talking about Tom, one of the first things that came to mind is the MGH credo. I don't know if anyone here knows it, but it's committed to memory in my mind. I think about this a lot. And it starts with the phrase, guided by the needs of our patients and families. So that was what we chose to start with at MGH. We will endeavor to give the best health care that is both safe and compassionate. If you think about that phrase, which leads off our mission and credo at MGH, I really was struck by so many parts of this case. So the needs of Tom were unique, very unique, different, heartbreaking, really. And the unique different aspects of each care member that brought to the team were the things that helped to be able to move Tom through all of his therapies. And I think that one thing that's very striking about this case is that from what Lorraine and the rest of the team said is that we were really guided by Tom's needs in terms of creating a care plan around what was necessary for him to get through the treatment. I think the other thing that stands out for me is safe and compassionate care. Safe for Tom is going to have many considerations. What feels safe for Tom, given his extraordinary history? And I think that that was something that was well cared for by the team. And compassionate. It's obvious from Mary and everyone on this table that has cared for him, the compassion that people have for Tom. And so those are the things that came to mind. I also am really, I sit on a national board, and I'll leave this as one of my last comments. You know that almost half of oncology care is delivered in this country in small, private community areas, which may or may not have great connections with superb community mental health care. And those private oncologists that might be caring for patients may not have access to an inpatient psychiatric unit, to clinical trials. Like you heard, Tom really felt a lot of pride in being able to participate in a clinical trial. That I think, and as I talk about my role where that's concerned, in the context of our country, that there is a tremendous amount of many patients, and we know this, who are not getting appropriate oncologic care because the people like you sitting in this room aren't available, aren't known, and to be honest, with the pressures of healthcare today, there's not the ability to take the time out of our day to be able to coordinate this very complex multidisciplinary care. That is something that we at MGH take very, very seriously. this is what makes this community very special, is that we have the ability and the flexibility to coordinate complex care that spans all of those layers that we talked about earlier today. And I'll be watching for the future because this is a crisis. And I think in oncology, there's more and more recognition of the crisis that is happening across in places that might be more remote or where we don't have the availability of more specialized mental health services. So I'll leave my comments there, and I appreciate the ability or the invitation to be here today and be with all of you. And lastly, I just wanted to thank you from the bottom of my heart. Every oncologist that's out there might seem, you may have different experiences with different oncologists, but I'll speak for them today by saying that we appreciate all of the help that and the teamwork that we are able to be part of in terms of caring for patients with serious mental illness.
Thank you, Dr. Lennis. That was very inspiring, and the challenge of how to enhance care for patients in where resources are limited is maybe one we all can think about in terms of what we can disseminate or what tools are available or how we can even help remotely in some way. This is something to think about for the future. At this point, it would be great to hear from our colleagues and friends in the audience what any comments they have or any questions they have for members of the panel, either about Tom or the care system in general. Any yes, thank you.
Just hearing his very traumatic upbringing, and then hearing the care they got, it just impressed upon me, that he may have been his first experience of what a family does for their family members. And I'm just wondering if that was healing for him going forward, aside from the cancer. Has your work with him at North Suffolk, or Chelsea, I'm sorry, changed? Is he changed in that regard? Yes, well, actually, I did start seeing him at North Suffolk originally, and then in 2008, he changed to the MGH Chelsea. But yes, things have evolved tremendously over the years. As I said in the beginning, I represented to him things he didn't want to think about. He did not want to know about the medication. He did not want to take the medication. Did not want to see a psychiatrist. He didn't want to come to any, or couldn't come to any terms with being mentally ill. But now there's a tremendous trust and regard. He always thanks us when he leaves.
Thank you for taking care of me.
Thank you for taking care of me.
After every session.
We can't always, he lacks executive function. I don't know if I said that this most recent time I saw him, he was off his medication. Oh, how come you're off your medication? Well, I don't know, that pharmacy doesn't want to give it to me, and they said they were going to call the police. So I called the pharmacy, and it turns out it's a problem with his insurance, and they were going to call the police because he was screaming.
And he growls at people.
He growls at
That's
people.
usually growling.
So, it took that afternoon, but we got that all fixed up. Oh, thank you, thank you. Thank you so much. Now, the next problem will come, and I can't count on him to call, but he does show up more consistently. Mary and I see him mostly, when he comes to a scheduled appointment, see him mostly together, and that has made the world of difference. Because originally with the other situation, I worked one day, social worker worked another day, and there the twain should meet. Seeing him conjointly, where we can both address his needs, has made a big difference, and he has a great deal of trust for us.
No, again, I think the real answer to that is him thanking us now after every visit. And to you, 99% of the time, it's thank you for taking care of me, and thank you for caring about me. So that's a huge difference and a huge cry from what his early experiences have been. And at 45, that he can at least have that experience, which he can now, is very, very rewarding.
Thank you. Do you have a question? Comment?
Thank you so much for sharing this story and really highlighting the interdisciplinary aspect of it. I'm wondering if you could touch on what had to be in place before the inpatient hospitalization for that first cycle of chemo that you had to do, and what it was like kind of liaisoning with all the different teams in the on the medical inpatient side for this very kind of.
Thank you for that question, Monique, and for coming from New York. An awesome sales psychiatrist. I'm going to be honest that if he had, let's just say, been referred to psychiatry, he never would have made it to that psychiatry appointment. And if it had just been, oh, he should get chemotherapy, he just wouldn't have gotten chemotherapy. And if it had been, well, he should go down to radiation, he probably, despite Lorraine being an absolutely amazing nurse practitioner, it required more than that. It required Amy spending 4 hours with him in radiation and me educating the nurse and walking him up to the inpatient unit and paging and discussing and advocating with the medical oncologist repeatedly about why I felt an inpatient hospitalization was absolutely the right thing to do for this person to get his curative chemotherapy. I said, well, that's not really what we do chemotherapy for. And I'm like, well, where would we go? Because, you don't receive chemotherapy in a psychiatry hospital. And there are only 20 beds in our whole hospital. I said, well, we don't really do. I usually have it for people who need it for cancer. And I said, this is part of his cancer care. I will personally go up to the unit and make sure he is okay. And I did, and the NP asked me to write the orders, and I said, that's not safe. You need to write the orders, but you can page me if you have a concern. And you know what's interesting? He was okay. He said some stuff. And he was sick, don't get me wrong. He said a lot of things that were frightening. He talked about voices, he talked about not wanting to be alive, but he also came, and he stayed, and he expressed gratitude, and he received all of his treatments. And for us, that was a huge thing, that he consistently stated, even being really agitated, I want my radiation, I'm gonna get in there, I'll do it.
And I might add, the engagement really began not just from the diagnosis. I mean, the diagnosis happened, but the engagement began with the collaboration between the team at the main campus and the community, because we're talking to him saying, they're our friends, they're really nice people, using the transference that he has towards us to be able to translate that and literally transfer it over to the Boston team. And, there were some comments like, okay, well, fine, then if she's your friend, I'll talk to her. That's great, whatever it takes. Yeah. And so it really required the team that knew him to get him to even show up. And we weren't even sure he was going to show up. So, but he did, and he met our friends, and he really came to love our friends. And, but that's where it starts.
And Lorraine's obviously special.
Well, yes.
No, but I think that really putting a plan in place ahead of time, having consistent team players, having education for those team members so that they are comfortable. I mean, the radiation therapy team that he worked with, he really got to know them. He saw them every day, and they were like friends to him by the end. They really came to love him. Even though, they would have to ignore those days when the voices were really talking to him, he would still get on that table and he would get treated. And we would remind him if he had bad times that, well, we are trying to cure you, and that would somehow resonate, that same consistent phrase that that's what we were trying to do. There were no surprises. We told him exactly what was going to happen, that there was going to be pain, there was going to be a lot of things that he was not going to like, but that they were going to cure him. He was going to be cured no matter what. But I think for him, from his perspective, he, on the day he left, said he had never, ever been in a place with so many kind people at the same time.
I wanted to add to that as well that I think some techniques, in my role, I often try to make a lot of change and get people to think a little differently. I think about access for all of MGH and how to get people to see more patients, and then also the patient experience. And what it involves often is asking what the goal is and then working backwards from there. Don't tell me what the barriers are first, but let's imagine the best case scenario. And in this case, wouldn't be safe or right to have the patient on a psych, in one of our 20 psych beds receiving chemotherapy. So then the answer is that we want to admit to an oncology floor. Well, this isn't a regimen that we normally admit for. That's probably what, the team was, and insurance, and, all the other things. So it's not stopping there, and what I counsel many of the team members that I work with is try to approach these with a lens of curiosity. What would it take to get to the outcome that we're looking for? How do we stay curious about this? How do we keep asking questions? How do we be creative? Curious is a very non-threatening word. So when you're talking to folks who bring up barriers to whatever the end goal is, I'm curious, what are your thoughts about how we can solve this problem? That is a magic word, and I preach the gospel of the word curious as much as I can, because it moves things forward, it gets people off their defensive block, and it starts to think about what the solution is. And so that's, I would say, one piece of advice. When you come up against something where there's the history of saying no because of very procedural problems, is to start from the solution, build partnership, and use the word curious.
That's really brilliant. The strategic design and innovation firm in IDEO, the way they address that same issue is that they always start with the words, how might we? Same idea. So maybe we'll hear from two more people, and then we'll allow us to get back on.
I'm going to string a couple questions together. The first is, how did you address the issue of the alcohol intake in the context of chemotherapy? Second is, what would you have done if he was unable or unwilling to reduce his alcohol intake? And the third is, how would it have changed your approach if this was not a curable cancer?
So I'll take the alcohol.
After the symposium.
Thank goodness, right? All right. So I think that really it's one of the gifts of working in a cancer center sometimes, that you get it to take a step back and be practical. And we're really trying to think about what's the best of this complex scenario that we're in. What's the best we can do for this person in this moment? And from my perspective, it is kind of we're trying to minimize harm. I was trying to make sure, which is why I really advocated for that specific visiting nurse. I wanted to have a sense of some lens of harm, so decreased alcohol use and communication about it. And the thing is, when he was in the hospital and he was taking his medication and he wasn't drinking, gosh, was he so much better. And I tried to be curious about that with him and the oncology team. And I really wished that we could get more. But we did the best we could. We wanted him to get his chemo, and we just put bounds around him to make sure that we were monitoring him more by having the VNA and doing the first one in-house. You want to do the non-curative?
I can do that, yeah. So if this were not a non-curative cancer, so cancers of the pelvis are some of the most awful things to die from in terms of them not being in control. You lose your bowel function, your bladder function. You can, if it spreads enough, it can cause cauda equina. You can be paralyzed. The amount of pain that you can experience in that area is terrible. And it's some of the worst things that we see would be a metastatic cancer in the pelvis. So to gain even control of the cancer, to try to avoid some of these awful symptoms, if it were a non-curable cancer, we would at least focus on trying to keep him out of trouble in those areas.
Sister. When she passed, I got a card to thank the team. And the family was like, why would you do that? And I'm like, they spent all that time and energy helping Mark through her transition. And I was just astonished that even though they weren't really close, because a lot of them were out of state, how do you address that? And is that helpful for you to receive like a thank you card in the mail? Is that something that you like, you don't like?
I think it's wonderful. I'll say that I have a drawer next to and I've saved every single thing that any patient or family member has ever sent me. And I open that drawer still when I have bad days. So it's perfect.
And I agree. We have the drawer.
Yeah. Yeah,
Thank you.
although we don't expect it, it's wonderful when we get it, and we all keep them. It's a wonderful thing. Yeah.
So,
Maybe just one more.
okay.
How do you distinguish or address or do a traumatic treatment? How do you distinguish for those people afterwards if they have PTSD? And what do you do about that when they already have a pre-existing mental illness?
Well, of course, if there is PTSD result to the treatment, then we're going to need to address that separately. In this instance, for as severe as his mental illness has always been, he did not have PTSD, thanks to the people sitting here, Kelly's team. He just felt so embraced. And as difficult as the treatment was, and as limited, despite his limitations, he could very well see how helpful they were to him. And he was with us this week, and as Mary said, and talking about what a tremendous positive experience it was for him.
But clearly, if PTSD, it happens, and clearly if there are PTSD symptoms as a sequelae to some medical treatment, be it cancer or something else, we're going to treat that as appropriate.
It's a great point to bring up because I think many people in the medical system don't recognize that patients have experienced trauma that has enduring effects related to alarms going off continually around them that they are like being in a sustained situation of threat, or the terror or the pain. Actually, one of our psychologists is studying a subset of women postpartum who experience childbirth as traumatic, and of course are reluctant to talk about the persisting symptoms so that's a whole nother area that I think we need to be aware of, because we may be congratulating ourselves for our successes sometimes in patients that are experiencing enduring symptoms from either terror, pain, or fear that they experienced either suddenly or in a prolonged way under our care. So thanks for bringing that up. So we're almost, I was going to say, almost brought us back on schedule. So thank you all for your comments. Thank you very much for the panel for your words.